I'm Alireza Fakhriraveri, and this is SARS-CoV-2 vaccines and Omicron. Do we need 2, 3, or 4 shots for immunocompetent adults? In general, coronaviruses are divided into 4 genera: alpha, beta, gamma, and delta. Alpha and beta coronaviruses are able to infect mammals like humans, but gamma and delta tend to infect birds. Now, beta coronaviruses specifically are divided into 4 lineages: lineage A, B, C, and D. There are a couple of coronaviruses in lineage A that cause common cold, and there are a couple of coronaviruses in lineage B, SARS-CoV-1 and SARS-CoV-2, which can lead to severe disease. And in lineage C, we have MERS-CoV, which can also lead to severe disease. There are also a couple of alpha coronaviruses that can cause the common cold in humans. Since the emergence of original SARS-CoV-2 in Wuhan, China, mutation in various parts of the virus over time has led to various variants of concern. The most recent variant of concern is the Omicron, or B.1.1.529, which has many mutations in the spike region of the virus, including mutations as well as deletions and insertions. Many of these mutations not only have led to higher transmissibility, but also to some evasion of immunity. For example, here we are looking at serum samples that were obtained from 13 people who had recovered from COVID-19. So on the y-axis, we are looking at 50% neutralization titer, and each column is a different variant of concern. Now, when we look at the neutralization titers for alpha compared to the parental strain, you can see that there is 2.3 times reduction in neutralization. And it's even worse for the beta variant with a 7 times reduction in neutralization. And it's not to say that every new variant will be worse than the previous one. For example, when we look at the Delta variant, there is only a 3.8 times reduction in neutralization, which is not as bad as the beta, but definitely worse than the parental as well as the alpha variants of concern. Now here we are looking at serum samples from 14 people who had received the BNT162 B.2 vaccine. We see similar results with the alpha variant having reduced neutralization compared to the parental strain. And of course, the beta variant has much larger reduction in neutralization. And we can see that the delta is not as bad as the beta, but still at least similar or worse than the alpha variant when it comes to neutralization. But things do get worse for Omicron when it comes to neutralization assays. So for example, in panel A, we are looking at sera from people who had received 2 doses of mRNA 1273. And you can see that compared to alpha, beta, and delta, Omicron had a much larger reduction in neutralization. In panel D, we can see the same results for the BNT162 B.2 vaccine. So these are sera from people who had received 2 doses of this vaccine, and you can see larger reduction in neutralization for Omicron. And of course, people who have recovered from actual infection as well. So people who had recovered from alpha infection, we can see that with Omicron, there is a larger reduction in neutralization. We can see even from people who recovered from beta natural infection, Omicron had much less neutralization. The same is true for Delta. However, we can see that in people who were vaccinated and recovered from infection, the neutralization looks much better for Omicron, perhaps suggesting that a 3-dose of vaccine might overcome this neutralization dilemma when it comes to Omicron. So here we have sera from 51 participants that received 2 or 3 doses of BNT162 B.2 vaccine. Again, on the y-axis, we are looking at neutralization titers. Here in the green, we can see the original Wuhan strain. And in purple, it is Omicron, red is beta, and blue is delta. We can see that after 2 doses of BNT162 B.2, of course, the neutralization was significantly reduced for Omicron. However, after a 3rd dose, we can see that the neutralization is much improved for Omicron to almost similar to other strains, including the original Wuhan strain. To make things more complicated, of course, Omicron also has subvariants, including BA.1, BA.2, and also BA.3. Initially, BA.1 was the predominant, and more recently, BA.2 has become the most predominant. There are quite a few mutations as well as deletions that are different between the two subvariants, so it's important to also keep that in mind. Here we are looking at samples from 24 persons who had received vaccination as well as a booster. First, with the prime, these are the results of neutralization 2 weeks after the initial BNT162 B.2 vaccination. So of course we see a significant reduction in neutralization for both BA.1 and BA.2. So 23 times for BA.1 and 27 times for BA.2. So both of them are pretty bad. Now before booster, this is basically before the third dose. So this is at 6 months after the initial vaccination. So these are people who received their second shot. And the sera was from 6 months after the first one. And you can see that still significant reduction in neutralization for both BA.1 and BA.2, more than, so that's pretty bad. However, we can see that after the third dose, so this is at least 2 weeks after the third dose, you can see much improvement in neutralization for both BA.1 and BA.2. So this is very promising. Now, in panel C, we are looking at the results from 8 individuals who were infected. 7 of them were vaccinated. 1 of them was not. So we can guess the person who was not vaccinated but got infected had essentially no neutralization against BA.1 or BA.2. And we can see that with people who were vaccinated and got infected, that infection kind of acted like a booster, so they had significant neutralization for both BA.1 and BA.2. Now here we are looking at the sera from people who have recovered from Omicron BA.1 infection. We have in panel A people who were previously vaccinated and no previous SARS-CoV-2, and now they're recovering from BA.1. You can see that their sera has a very good diversity of neutralization across different variants as well as BA.1. In panel B, we are looking at unvaccinated people who did not have an infection before and now they have recovered from BA.1. You can see that although they have developed neutralization against BA.1 as a result of BA.1 infection, they lack the diversity of neutralization against other variants of concern as well as the ancestral strain. In panel C, we are looking at people who were vaccinated and had a previous infection, and now they have been infected and recovered from BA.1. You can see that again, they have a good diversity of neutralization against different variants, as well as BA.1. And lastly, in panel D, we are looking at unvaccinated people, but they had previous infection and now recovering from BA.1. So that previous infection kind of a little bit improved the diversity of neutralization against other variants, but it's kind of all over the place. So perhaps the best approach is to get vaccinated to get the most diverse neutralization capacity. Now, all these neutralization studies are based on antibodies. Of course, the immune system is more than antibodies. We do have T cells, and T cells effectively recognize different variants. They are very, about 93 and 97% of CD4 and CD8 T cell epitopes are 100% conserved across variants. So it's really difficult for these variants to evade immunity from T cells. So T cells are really important when fighting severe disease. Here on the left-hand panel, we are looking at spike-specific CD4 T cell percentage. And we can see that in vaccinated individuals, between the wild type and the Omicron variant, there is not much difference. In people who have recovered from infection, so in convalescent sera, you can see still a little difference, but not much difference between wild type and Omicron. And then on the right-hand panel, we can see that spike-specific CD8 T cells. Also in vaccinated individuals, there's not much difference between wild type and Omicron. and the difference can increase in patients who are not vaccinated and have recovered from infection. Now, going back to antibodies to quickly look at if we need a fourth dose of mRNA vaccines, here on the y-axis we are looking at IgG binding antibody units. And first we can see individuals who received 2 doses of BNT162 B.2. Initially 4 weeks after the second dose, the antibody levels are pretty high and then they start to wear off. And then we can see that once individuals get the third dose, the levels go very high, even higher than the second dose. And then again, it's a function of time. So as time goes on, these levels start to wear off. And then we can see that if we give a fourth dose with BNT162 B.2, again, you can continue to increase these levels back to pretty much where you start, but it's only natural that in time this will start to wear off. So you can see that with even mRNA 1273, a fourth dose will increase these antibody levels. Whether this is clinically significant or not is the question. So one thing we can do is again to look at neutralization titers. So here on the left hand side we are looking at live virus neutralization efficacy. We can see that 5 months after dose 3, neutralizations really get reduced for Omicron. So although this is still detectable, but it has significantly reduced compared to Delta and wild type. And a fourth dose of BNT162 B.2 significantly increases neutralization capacity for not just Omicron, but also for Delta and the wild type. So this increases neutralization capacity. And we can see that as time goes on, this is 2 weeks after dose 4, this is still pretty stable. On the right hand side, you can see similar results for the mRNA 1273 vaccine. You can see that 5 months after dose 3, neutralization is reduced for Omicron, although it is still detectable. And you can see that the dose 4 will increase neutralization for not just Omicron, but also for Delta and wild type, which kind of stays stable after 2 weeks. Here we are looking at waning immunity against Delta. So although antibodies wear off as time goes on, here we are looking at, on the x-axis we are looking at time since full vaccination, and the y-axis we are looking at vaccine effectiveness. So we are actually looking at clinical outcomes now. So this is in panel A, the results for actual infection. But you can see that we saw that as time goes on, antibody levels wear off and neutralization capacity, goes down. And this translates to reduction in efficacy or effectiveness against infection. So as time goes on, people are more likely to get infected with the virus. Now, whether this is important or not is a matter of, the outcomes that we are interested. So we are interested in, people progressing to hospitalization or ICU admission or, ending up in the morgue. So mortality would be the ultimate outcome. So here in panel B, we are looking at, on the x-axis, we are looking at time since full vaccination. And on the y-axis now, we're looking at vaccine effectiveness against hospitalization. And we can see that although over time, people are more likely to get infected because antibodies wear off, effectiveness against hospitalization remains pretty stable. And this is, with 2 doses of vaccination. Since effectiveness against hospitalization is more important than effectiveness against infection, let's compare the effectiveness of 2 doses versus 3 doses. This is specifically with Delta variant. So you can see that with people who have received 2 doses of the mRNA vaccine, the results show that vaccine effectiveness remains very high. So even beyond 5 months post-vaccination, 82% effectiveness against hospitalization. And this number can go even higher with the 3rd dose of the vaccine or a booster. Now the numbers look bad in the last row, 4 months beyond the booster, and this is because this subgroup had a very small sample size. So you can see the confidence interval is very wide, from 14% effectiveness to 93. So this is just an anomaly because of the small sample size. But in general, you can see that third dose increases the vaccine effectiveness against hospitalization well into the 90s. But what about the Omicron? So we can see for Omicron, people who receive 2 doses, vaccine effectiveness against hospitalization drops into 50s, 60s, and 50s. So 54% effectiveness beyond 5 months after second dose. And you can see these numbers go higher with the third dose. So it can be restored into 80s, 70s, and 90% effectiveness. So this is a good reason to get boosted to guard against hospitalization, specifically for Omicron. Now here we are looking at 2 retrospective cohort studies from Qatar that included over 2 million patients. Here we are looking at effectiveness against symptomatic Omicron infection. In panel A, this is 2 dose versus 3 doses of BNT162 B.2, and you can see a large increase in effectiveness going from 2 doses to 3 doses. And on the right hand side, we are looking at the same thing with mRNA 1273. And you can see that again, going from 2 to 3 doses results in improved effectiveness for symptomatic infection. Now, this actually shows you that the benefit of the third dose is much larger when it comes to BNT162 B.2 compared to mRNA 1273, and this is because 2 doses of mRNA 1273 is already very effective. So the third dose, although it improves it, the difference is a little smaller. Now, of course, hospitalization effectiveness is much more important. So in the last row, we can see that third dose of BNT162 B.2 has a vaccine effectiveness of 76%, and the sample size was too small to calculate that for mRNA 1273. Now here we are looking at a non-randomized open label study from Israel. They compared a 4th dose of either BNT162 B.2 or mRNA 1273 4 months after the third dose. In panel C, we are looking at efficacy against infection. So we can see that with the 4th dose, there is improvement in efficacy against infection. The same results is true when we look at the mRNA 1273. Lastly, another study from Israel, which is an observational study including 182,000 matched pairs of patients, looked at the effectiveness of the 4th dose. Of course, they showed the effectiveness is improved with the 4th dose when it comes to infection, but also for hospitalization. So when you look at hospitalization, you can see the effectiveness is 68%. The same is true for COVID-19 related death. So 74% effectiveness when it comes to death. Now, this study specifically looked at individuals aged 60 years or older, and they had received their 3rd dose at least 4 months prior. So these results only apply to individuals 60 years or older. However, a big limitation of this study is that it had a short follow-up. Now, here are recommendations from the CDC. So for adults 18 years and older specifically who are immunocompetent, of course, the 2-dose primary series are recommended using mRNA as the preferred vaccines. And for boosting, at least 5 months after dose 2, it is recommended for everyone. And then, of course, we have these footnotes when it comes to boosters. So essentially, persons 50 years of age and older may receive a second mRNA booster dose at least 4 months after the last dose is the latest recommendation when it comes to the 4th dose. And as far as the primary series, an 8-week interval may be optimal for some people, including males 12 to 39 years of age, because of the small risk of myocarditis. It can also increase the vaccine effectiveness. Now, while for the primary series, it's recommended to give the same mRNA vaccine. So if it's, BNT162 B.2, it's recommended for both of them to be BNT162 B.2. But for the booster, it's okay to mix with other mRNA vaccines, but it is recommended for the boosters to also be mRNA. When it comes to viral vector vaccines, these are not preferred, so it is only for select patients who cannot take mRNA vaccine. But even for these patients who get their primary as the Janssen vaccine, a second booster is recommended for patients who are 50 years of age or older who received a primary dose of Janssen vaccine. Thank you.